The last speaker is the Professor John Prowle. John is the senior physician, ICU physician in the London School of Medicine and Dentistry, and also he is the probably is the one of the famous ICU physician and long to the Chinese colleagues, and he is the one of the important member organizations such as the ACI, as well as the clinical organization, and he has published a lot of papers on the clinical care nephrology, and a lot of the book chapters. Today, John will give us the lecture. It's about the targets for hemoadsorption in major trauma. Welcome, Professor Prowle.
Thank you very much, Jiong, for your generous invitation. So I will share my screen for my slides. So I hope you can see my slides.
Yes.
Yeah. Can you see the normal view or the presenter view?
I think it's the
normal view. Excellent. Oh, very good. Okay, so it's my great pleasure to join all of you again online. My apologies, I'm on call today, so but I've got a bit of free time to speak to you. So I'm going to talk to you about targets for hemoadsorption in major trauma, an evolving area where I think there's a lot of potential targets for future research and development. So a few disclosures, but of course, very grateful to Jaffron for their support in terms of developing future studies with their hemoadsorption product. But this is obviously a more general product about talk about hemoadsorption in general. And so let's move to trauma. And so these days, we have very sophisticated major trauma systems, and they expend a huge amount of technical resources to taking physicians to major trauma victims in the field, providing them with advanced interventions, including surgical interventions in the field, pre-hospital transfusions, other interventions such as aortic occluders, and even developments such as pre-hospital ECMO are being considered in these cases, all in order to get patients to hospital, give them damage control surgery, and then land them in the ICU. And there's a strong argument that we should be adopting a more sophisticated approach to treating these patients in the ICU to reflect the level of sophistication that is being provided to them in the pre-hospital and early hospital phase. And this is really the pattern that we see here, that there's been an improvement in pre-hospital survival over the years. This is comparing 2009 to 2015 in UK major trauma systems. But this has somewhat reflected by an increase in late mortality and rather than an improvement in late mortality, overall an improvement in survival, but really suggesting that we should tackle these patients as they're coming into and throughout their ICU stay with the kind of vigor that we applied to them in terms of improving their pre-hospital care. And so really, I think there are four major groups in major polytrauma who have damage control surgery. There will be a group who are moribund at the outset that either die on the scene in DED or in theatre. And to some extent, in order to push the envelope and save patients who are perhaps would have died before, we have to accept the fact that we will take some patients and find that they will not survive. And overall, there may be not much we can do to alter their outcome. Some injuries are just too severe. But really what we want to tackle is these in yellow here. So first of all, those patients who die in the ICU with multi-organ failure and refractory shock. They've survived their initial injury, but they're unable to survive the consequences of their initial injury. Then there are a group who do well, and hopefully they'll continue to do well. But then there were another group who have prolonged ICU stay and long-term complications or late death in hospital, particularly things like infective complications or other organ injuries. And maybe something that we can do up front will lessen the severity of their initial insult. They might survive, but actually what we want to do with them is survive with a better clinical course, have less long-term complications, not suffer the rigors of a long ICU stay. This just summarizes some of the the problems we see in the ICU after major trauma, vasoplegic shock from tissue ischemia and reperfusion injury, myocardial depression from similar, and often the combination of vasoplegic shock and myocardial depression can be extremely difficult to cope with without resource to extracorporeal support such as ECMO. Inevitably, the effects of fluid overload, the effects of both primary and secondary abdominal compartment syndromes, primary from the initial injury and secondary related to perhaps fluid overload and systemic inflammation, acute kidney injury, acute lung injury, ischemic hepatitis, ischemic limbs, the effects of immunosuppression related to the severity of trauma and then late infection, and the immunosuppression both being a disruption of innate immunity and tissue barriers and an immunological process. And then obviously we're particularly concerned about acquired brain injury, acquired injury to other organs. Many people who don't suffer a TBI may actually suffer significant cognitive effects long term, or even indeed develop cerebral edema and die, and related to either initial hypoxic injury, but indeed to secondary injuries that may occur down the line. This occasionally occurs in patients with perhaps severe pelvic trauma. I've certainly seen it. Can we do something to modify these processes? What interventions do we have in the ICU? Well, we have our traditional ICU care, lung protective ventilation, hemodynamic optimization, or other forms of advanced hemodynamic support. We can provide renal support. We can provide nutritional support. But is there a role for hemoperfusion in order to alter the course of patients who have suffered an acute injury and potentially can be caught relatively early in these processes? This just illustrates the sort of the long-term element. This cartoon applies to all forms of critical illness, but I think in particular to trauma. Really, we're talking about patients who developed prolonged or chronic critical illness associated with persistent inflammation, immunosuppression, and catabolism syndrome. And really what we're talking about here is patients who are going beyond the early phase where we both get inflammatory effects and compensatory immunosuppressive responses, deviation from hemostasis, but perhaps not in either direction, but in both directions, a kind of immunoinflammatory chaos. And those who survive, some may recover rapidly, but others may have a combination of both persistent inflammation and progressive immunosuppression. This is associated with other organ failure. It's associated with infection. It's associated with protein catabolism, cachexia, ICU-acquired weakness, prolonged requirement for mechanical ventilation, and if they don't suffer an indolent death, poor functional outcomes, poor rehabilitation, increased cost and length of stay. A number of people have looked at this in the context of trauma. This is a small study looking at patients who admitted after major trauma who survived early but suffered prolonged ICU length of stay. And what you can see is that this is a significant portion of patients, not the majority, but certainly one where actually they consume the majority of the resources, and they tend to be older, they have more severe shock, greater organ failure severity, and they suffer more complications. They're more likely to be discharged long-term care settings. They have higher mortality, lower general health measures, and along the line, they have consumed an enormous amount of healthcare resources. So what's the sort of the etiology, the cause of these processes, both in terms of the short-term fulminant causes and the long-term chronic critical illness and the PICS type syndrome? This is related to activation of the immune and inflammatory mechanisms in early in the stages of trauma and the generation of an ongoing response. And this is kind of illustrated here. We have, first of all, in major trauma, injury. So we penetrating trauma, thermal injury, blunt trauma, ischemia, reperfusion. All of these can cause tissue damage. Tissue damage involves the release of a number of damage-associated molecular patterns, and these are often intracellular and particularly intranuclear products that can activate inflammation when released into circulation, but also products that are related to the innate inflammatory mechanisms, such as coagulation products, fibrin degradation products, complement components. And these go on to then activate immunological and inflammatory cells to cause a sort of disordered pro and anti-inflammatory cytokine response, and a number of prototypical inflammatory mediators are listed below. These in their own right can cause further tissue damage and remote organ injury, but obviously the patients also have immunopresis risk of infection, and infection can release pathogen-associated molecular patterns, which can go on to continue to drive a process of inflammation and chronic critical illness in our patients. Now, hemoperfusion is an attractive intervention to provide to our patients. You've heard from earlier talks, hemoperfusion can target these inflammatory mediators, but by the time you're getting altered inflammatory mediator production, you already have an altered inflammatory and immunological response. These are coming from immune and inflammatory cells. Maybe some of the things we're seeing in the blood are spillover effects. Hemoperfusion is not going to be particularly efficacious about cells in tissue, in situ in tissues. It's really addressing more sort of endocrine effects of these mediators. If we can intervene early to remove these damage-associated molecular patterns or any pathogen-associated molecular patterns that may be released early on in trauma, such as through gut translocation, maybe we can ameliorate these immune and inflammatory derangement before they even get initiated, and have much more potential to alter the course of our patients. That's the theory. We need to test it in practice. Here's another cartoon just demonstrating some of the many pathways that are involved in the release of mediators in major trauma, involving the obviously an interaction between the coagulation system, the complement system, the endothelium and immune cells, as well as neuroendocrine responses. And it's a complex process, but the earlier in this pathway we can intervene, the better the response is likely to be. This summarizes damage-associated molecular patterns. Prototypically, endogenous nuclear mitochondrial cytolytic molecules that have physiological functions inside cells activate innate and adaptive immunity. A number of target cells really activated through pattern recognition receptors, prototypically toll-like receptors that cause the activation of cytokines, chemokines, and other soluble factors. These are perhaps associated normally with local inflammatory responses. The systemic effects of trauma, however, then cause systemic responses that may be very disadvantageous to our patient. These are the kind of things that we're talking about. Nucleic acids, other proteins associated with DNA, including HMB1 and histones, induced proteins such as heat shock proteins, small nucleosides, S100 proteins, and also heme myoglobin and other sources of heme from things like cytochrome proteins released from damaged cells that can have cytotoxic effects. I'm not going to talk more specifically about hemolysis and rhabdomyolysis, but this is a very important process in major polytrauma with massive transfusion and tissue injury. And as you say, these are very important prototypical damp that is more specific to this setting and is potentially an attractive target for an absorptive therapy. But obviously, we've got to get in early before we're activating this intracellular process, such as the activation of the NLR3P3 inflammasome, which is a very potent activator of a number of inflammatory and immunomodulatory pathways intracellularly and potently activated by a number of DAMPs. Again, just an illustration, various DAMPs are activating a number of these pattern recognition receptors, most importantly, various toll-like receptors, which result in intracellular signaling transduction, translocation of things like NF-kappa beta to the nucleus and other, which induce transcription of cytokines in inflammatory cells. We can kind of deal with the downstream effects of their release, but if we can deal with the upstream effects, then we may be able to more potently alter the time course of our patients. So hemoperfusion, can this do this? Well, we need to discover. You're well aware that hemoperfusion uses, of the types that we're discussing in this session, uses styrene benzene copolymers, using a bead structure that has enormous surface area, but is very biocompatible. Blood and cells are able to circulate around the beads. However, smaller molecules and the plasma water are able to access the microstructure of the beads, and by convection interact with the very complex surface, and then over very small diffusion distances, mediators dissolved in the plasma can interact with the enormous surface area and bind to the membrane and thus be removed from the blood returned to the patient. The mechanism of absorption involves weak ionic bonds, van der Waals forces, and strong hydrophobic bonds, and with very high surface to volume ratio. And we have different sorbents available, classified according to the size of the pores and the inner structure to target different types of molecules. Jaffron make a range of products that are somewhat attuned to the molecular range that we want to target. And in the context talking about major trauma, we're looking at cytokines, complement, free hemoglobin, and these other DAMPs that I've talked about. And we would favor a cartridge like the H380, which would remove this wide range of molecular weight, including a number of important mineral molecules. So the questions we have are hemoperfusion in trauma, massive trauma, and also potentially patients who require cardiopulmonary bypass, but I'm not talking about those today. More specifically, is timing of therapy. We need to think about whether we use it as an isolated treatment or combine it with renal replacement therapy. And I'll talk about that perhaps a bit more in questions. Again, anticoagulation, frequency of cartridge change, duration of therapy, target molecules demonstrate efficacy, and safety parameters. So first of all, let's think about target molecules and whether we think that hemoperfusion has a chance of working, whether we can apply it in the clinical setting. There have been a number of small studies. This is a nice one that looks at a range of prototypical DAMPs and their removal with a hemoabsorptive cartridge, in this case, the CytoSorb device. And what you can see is you can get a very effective removal of C5a, HMGB1, procalcitonin, S100, and a number of these are very important molecules, we think, in the pathogenesis of trauma-associated multi-organ failure and vasoplegia. And so clearly the device will do what it says on the tin in terms of removing these from blood. And if we could apply it early on, then we could be able to see whether we can replicate this kind of performance in vivo. So target molecules we're thinking about, well, I've mentioned myoglobin and hemoglobin, complement components, clotting degradation products, endotoxin potentially, because as I said, bacterial translocation may play quite an early role in trauma. And then these more, what I would call classical DAMPs, which is really, I'm talking about these things released from damaged cells in particular nuclear components. These include DNA, but they also include the protein structural components of DNA, and these may be particularly important DAMPs, and they may be good ones to study in pilot studies. I'm particularly interested in histones. Histones are small basic proteins that complex with DNA in the nucleus of almost all eukaryotic cells. There are 4 core histone molecules that make up the histone octamer that is then combines with DNA to make the nucleosome array. The molecular mass of these histones are range between sort of 10 and 16 kilodaltons. And overall, in your body, you've got as much of sort of histones and other nucleosome proteins as you have the mass of DNA. And so we sort of think of DNA being released into the plasma, and we forget about the protein components that may be very important. There were a large number of organ-specific effects of histones on a wide range of cells, but their mechanisms include direct cytotoxicity, TLR4 stimulation, immune cell activation again of this NLRP3 inflammasome, which I won't go into more detail, but is this very important signal transduction mechanism as a response to damage or pathogen. And you can prepare histones, and you can get nice preparation for things like thymus that you mash up and prepare a purified preparation of histones, and you can inject them in animal models, and they're associated with quite significant mortality and morbidity in animal models where you inject them. Primarily up front, they have direct alveolar toxicity, which causes ARDS, but there are a number of other distal organ injuries that we see, and some of that will be direct and some of that will be secondary to lung injury, but they certainly have effect on pancreas, kidney, liver, heart, as well as lung. And the histone release is correlated with severity of disease and tissue damage and major trauma. This goes into this mechanism a bit more. Again, histones can come from inflammatory cells themselves that may die during inflammatory responses, or they may come from parenchymal cell necrosis. There are a number of endogenous mechanisms that seek to impede the toxicity of histones, as you would expect, but these become overwhelmed, and you have a number of deleterious effects, particularly, as I said, toll-like receptor activations, also effects on the clotting system, stabilization of extracellular DNA, which is itself an important damp or could be associated with autoimmunity. And we get particularly vascular injury, tissue injury, systemic inflammation, and thrombosis. So what's the evidence for this? Well, there's a lot of evidence, but I'll just cherry pick a few things. So this is a study that mixed some clinical and animal data and in vitro data. But this just shows that in panel A number of polytrauma patients, that the release of nucleosomes early on was related to the severity of traumas measured by the injury severity score in a linear fashion. But even patients with relatively low injury severity had detectable increase in circulating nucleosomes. Interestingly, the nucleosomes fall, but actually the histones which are released from nucleosomes begin to continue to rise slightly in the first 24 hours and remain elevated for some time in the ICU. And this just shows the difference between normal patients in panel C and the trauma patients in terms of histone concentrations elevated, but very significantly elevated some patients. This now moved to in vitro. Increasing concentrations of histones in vitro are related, cause cell death. This cell death is actually worse in serum-free conditions, so in cells that are really stressed. The additional stress of histones causes them to die more readily. The last panel actually just shows that you can is taking serum from patients who have trauma, sepsis, and pancreatitis, and showing that all of these cause cellular death in an in vitro model, but the cellular death it can be blocked by an active antihistone antibody. whereas a control antibody or serum alone do not block the death associated with the serum from patients in these disease states. A normal patient serum does not cause cell death. And so quite potent evidence for the cytotoxicity of histones. This is moving to an animal model. We've got lung here at the top. Panel A shows normal, shows lung from mice. In the top, they've been injected with histones. In the bottom, they're in a trauma model. And the panel A is the control. No trauma, no histones. Panel B is the lung injury seen in trauma or seen in mice injected with histones. C and D are liver and renal injury seen in the histone or trauma mice. And injection of histone associated with death. And that is inhibitable by the injection of an antihistone antibody. Trauma is associated with a large increase in histone H3, which continues over time. There are some effects on bloods as well, although it's a little early in the clinical course. This is another model, also an animal model from another publication here from the American Journal of Pathology a few years back. Interesting, this is looking at a ischemia reperfusion model and actually a sepsis model using LPS, because any form of cellular injury can cause release of histones, but obviously we've seen it's particularly potent in trauma. And then we can also inject histones. And what we can see is the injection of, so basically tissue injury and inflammation causes histone release. Higher doses of histones causes decreased survival and is associated with lung injury, as seen here in this picture. And the histones are linearly associated with release of TNF-alpha and IL-6 and IL-10, and to a slightly lesser extent, IL-1 beta. So really sort of closing the loop here. And to cut a long story short, increasing doses of histones cause increasingly severe lung injury, liver injury, and kidney injury. So can we remove histones with hemoabsorption? Well, we can in vitro. This has been shown. So this study is looking at perfusing beads from a hemoabsorption device with histones of various concentrations, and you can very effectively remove the vast majority of histones, and the saturability is really quite high. So you, even with a concentration of 700 micrograms per ml, which is higher than we see in the in vitro settings, a 92% reduction. And this in panel B is actually blood from patients with major trauma. And you can see a high concentration of histones. And if you treat that serum in vitro, you can substantially reduce the histone concentration. What we'd now like to do is carry the device to the patient and see if actually we can produce an effect in vitro of these highly cytotoxic elements. The research question is hemoabsorption with a device such as the HA380 useful at removing histones in the adult major trauma population. We're proposing to look at it in combination with renal replacement therapy. And the reason for that is that it now enables me to use citrate anticoagulation, which is appropriate for a patient with significant coagulopathy. Is it safe to use, and will it be effective in removing a prototype molecule such as histones? And if that is the case, then we can go on to do more definitive studies with more patient-centered outcomes, such as multi-organ failure and eventually survival. So I'll end there and take any questions about this very exciting topic.